Okay, so we're going to get caught up tonight with Chapter 7 and Chapter 8. And we're also going to do a little bit of surfaces and tooth numbering in the middle. And just to warn everybody, at about 7 o'clock, there's a fire drill here where I am. So I'll have to step away from the computer for like 2 minutes maximum. So you get a 2-minute break around then, a chance to stretch your legs and chill for a second. Okay, so we're going to pick up where we left off with infection control. I will post a couple reviews on Evolve for chapters 5 and 6. If you'd like to go and do them, you do not have to. They're not required. And we will just sort of run through chapter 7 and 8 quickly because the material is important. And then we're on to our next part, which is the beginning of clinical care. So our learning objectives, again, are mostly centered around how we're going to treat surfaces in this chapter. So chapter 7 is how do you treat surfaces mostly. We do talk about instruments a little bit, but mostly we will talk about those in chapter 8. So the bloodborne pathogen standard, the BBP, says that we either need to barrier or pre-clean and disinfect our surfaces in between patients. So a barrier is anything that is fluid resistant, and typically these are either a blue or a clear sticky wrap that we can attach to things. But we typically only put barriers on things that are difficult to clean. Otherwise, you're not really saving any time. Because if the surface is something fairly smooth, it's a lot easier to wipe it. Because most of us tend to barrier and then wipe anyways. So barriers are a time saver. If you use them the right way, you don't have to pre-clean and disinfect the surface. Couple examples of what we put barriers on here: light handles, curing lights, the patient mirror, stool adjustment handles, any drawer handles. So things that we touch often, but are not going to want to go back and disinfect. Mouse and keyboard are also really important to barrier. Anything that is an electronic switch, X-ray control, suction control, things that have any crevices or little textured surfaces are best done with barriers. And then we talk about our disposables, the things that are single use only. And there are many items in the dental office that are given as disposable, and there are some that are both disposable or reusable, and it depends on the material that they're made out of. So an example that I use often is an impression tray. So an impression tray, if it's made of metal, is meant to be sterilized after use and reused again. An impression tray made of plastic is meant to be thrown out after use. The same with air water syringe tips, Profi angles, which we met both of these things last week, although Profi angles are new in some ways. The vacuum line trap, and we'll take a look at these. All right, who's stressing? No more sighing, it's okay. Because me too. This type of tray is going to end up being reusable, whereas this one, single use only. Throw it away after you use it. And the same, we're looking at the Profi angles and cups. So this part is the angle. This is the Profi angle. And this is used to polish two surfaces, and you will use these a lot. And you'll see this angle over here is made of plastic. So which one is disposable? Well, it's easy to tell, right? So if it's metal, think twice before throwing it out and make sure that you check on whether it is disposable or not. But this part of the Profi angle is the Profi cup. And the Profi cup is always disposable. So if it's attached to a metal angle, you've got to throw this away and then sterilize this part. So you have to throw this out in order to sterilize this properly. So knowing our Profi angles and cups and the difference between the two. Some things that are always single use: Profi cups and brushes, as we just said, sharps containers, patient napkins, needles, syringes that are used to deliver irrigation solutions like saline solution or other solutions that we use. All of these are single use only. They're not meant to be reused again. So pre-cleaning and disinfecting is what we do to any surface in the dental office that becomes contaminated during treatment. And to recognize sort of the way that we have to think about this, it is a two-step process. So pre-cleaning is when I wipe it the first time. Disinfecting is when I wipe it the second time. So a surface cannot be disinfected if it is not clean first. So even though we can't see the microbes, remember that they're there. So the first wipe cleans the surface. The second wipe disinfects the surface. And that surface has to stay wet for the time that the manufacturer says that it takes to kill tuberculosis. So acceptable disinfectants that we use in the dental office, to remind ourselves about last week, reach a benchmark. And that benchmark is TB kill time. So how long does it take this disinfectant to kill tuberculosis is how long I want the surface to stay wet after I've pre-cleaned and disinfected. And so this is most effective on smooth surfaces. And then if we don't think we can do this, we barrier. So some terms to know when it comes to disinfection and sterilization and infection control in general are the definitions of sterilization and disinfection. Disinfection kills some, but not all. Sterilization kills all. Disinfectant is what's used to disinfect. Antiseptic is what is used on living tissue. And the two should never be used interchangeably. So a disinfectant should never be used on skin. It should only be used on countertops. And the way that we say this is we say disinfectants are for inanimate objects, which means things that are not alive. And antiseptics can be used on living tissue. Anything that has a sidle after it means that it kills whatever is before it. So homicide is to kill a man or a person. Sporicides, germicides, virucides all kill what comes before them. So a virucide kills viruses, a sporicide kills spores, and a germicide kills germs in general. So this the sidal part of that is the important part of the word to recognize. Some terms to know about the touch surfaces or the surfaces that are termed as clinical contact. We have touch, transfer, and splash, spatter, and droplet. Splash, spatter, and droplet are the ones that we typically don't touch during treatment, but may have the aerosol settle on them after a day. And so those should be cleaned daily. But touch surfaces should be cleaned in between patients. These are touched directly by either the dentist or the assistant. And transfer surfaces are anything that we put instruments onto. So both of those have to be cleaned in between patients. Other surfaces in the dental operatory are floors, walls, and sinks, the housekeeping surfaces. Critical, semi-critical, and non-critical are how we talk about our instruments and what we do with them. So a critical instrument is one that penetrates bone or soft tissue, meaning it gets bloody. So these are our surgical instruments and handpieces, scalpels, forceps, things like that we use for surgery. Semi-critical are those that touch the inside of the mouth, but have only a moderate risk of transmitting disease. And these either need to be sterilized or high-level disinfected. If an instrument is critical, it has to be sterilized. Non-critical instruments are ones that we touch only. They never go into the mouth. but we often are touching them, and an example of that would be the x-ray when it's placed up to the face. So my hands are in your mouth, and then they're touching the x-ray tube, but the tube never goes in your mouth. So that's a non-critical. Another example is a blood pressure cuff. And so here are some visuals of that, of critical and semi-critical instruments that we use in dentistry. Any burrs, any files, anything, handpieces are all considered critical instruments and therefore have to be heat sterilized in between patients. And some examples of non-critical instruments. This is a face bow, funny looking contraption used when we are making dentures for patients most of the time. And then some other things that we touch but don't put in the mouth. So we talked about what disinfection means and the difference between a disinfectant and an antiseptic. And then we want to make the distinction between disinfection and sterilization, which we spoke about. Which brings us to the levels of disinfectants that we use in the dental office. So I've mentioned that a disinfectant has to kill tuberculosis in order to be used correctly between patients in the dental office. And we call this a hospital level intermediate disinfectant. It also has to have an EPA registration number. So your book goes into a list of all of the types of chemical disinfectants that we use. And this is where it can get really tough to sort of figure out what on earth are they talking about. And so I'm just going to go through each one really quickly, highlighting both their strengths and their weaknesses, or their pros and their cons, and what we use them for. And most of this is probably a little more important when it comes to the certification exam, the actual words. What's important in clinical practice is to know how to perform the action of disinfection. Okay, so sodium hypochlorite is a fancy way of saying bleach, and we are no longer using bleach for disinfection in dental settings. We do use products that contain bleach, but bleach by itself is no longer acceptable. Alcohol, same thing. We use products that contain alcohol, but alcohol by itself is not recommended as a disinfectant. Alcohol is better on the skin, typically, than it is on the surface. It's a lousy cleaner. So there are some disinfectants that are higher level than the one we use on the surface. And the higher level ones are not used for surfaces. They are only used for soaking instruments. And we call that immersion disinfection. And so I always think about it as taking a bath. So if my instrument cannot stand up to heat, so maybe it's plastic, but it is reusable, I'm going to put it into a bath to sterilize it. Sterilization and high-level disinfection typically depend on how long you leave it in there. So what's the difference? Well, the difference between disinfecting at a high level and sterilization is a spore or two. So spores can survive high-level disinfecting, but sterilants kill everything. Just a note about personal protective equipment, really important to wear during any time that we are handling chemicals. And we're going to see this when we talk about how we do this at the end of the slides. Glutaraldehyde is one of our high-level disinfectants, and most of us in the field, we just call it glute because glutaraldehyde is a really long word. Glutaraldehyde is never used on surfaces. It can stain some plastics, and it is really toxic. And so if you use it on an instrument, you've got to rinse it off before you use that instrument on a patient. Chlorine dioxide is also a high-level disinfectant and a sterilant. So if I leave the instrument in the solution for 3 minutes, it disinfects. If I leave it in for 6 hours, it sterilizes. And chlorine dioxide has to be made daily, which is another problem with it. It has to be prepared each day by the dental assistant. OPA is another good alternative. And this is what most offices are using now because it is not as toxic as glutaraldehyde. So orthophthalealdehyde is its actual name, but OPA is how we say it because that's much easier. And so I can high-level disinfect in 12 minutes, which means that if I have an instrument that is plastic that I need to reuse on the next patient, I can disinfect that in 12 minutes to a level that it's acceptable to put it back into a mouth. Now, I can't do surgery with that instrument. Any instrument that's going to play in a patient's blood has to be heat sterilized. But instruments that are not going to be, that are just going to be put in the mouth, don't need to be heat sterilized unless they can be, and then they should be. It may stain and turn plastics blue-green, and it is more difficult to sterilize with OPA. So this is a chart that outlines the levels of disinfecting, and it goes from high, which is a chemical sterilant, to low, which is a low-level disinfectant. And it tells you exactly what it kills on this, and I'm just going to go through what you should use it for. So the chemical sterilant is for soaking instruments that cannot stand heat. The high-level disinfectant is the same as the chemical sterilant, but used at a shorter time. So this might be 6 hours. This one's only 10 minutes. All right? So what's the difference between the two? A couple of spores. All right? The next level is the intermediate level EPA registered disinfectant or hospital disinfectant. And this is what is acceptable for use in cleaning the operatory in between dental patients. The low-level disinfectant is for floors, walls, and sinks, or housekeeping surfaces, and can also be used on, say, the X-ray tube head, a blood pressure cuff, a curing light, if you were to use it that way. So anything that doesn't go in the mouth can have the low-level disinfectant. So low levels kill most of the viruses, almost all of them. Intermediate levels kill the viruses plus TB, polio, yeast. High levels kill all of these things plus tetanus and spores. And then chemical sterilants kill everything, all of the microorganisms. So this is a really good table to sort of squish your knowledge together on the chemicals of disinfecting. So again, we said immersion was taking a bath, and a lot of times we put impressions or impression trays that are reusable and other plastics in for immersions. We call this cold sterile in the dental office because it's for using things that can't withstand heat. Some additional techniques for asepsis, or to be without pathogens, are your HVE, your pre-procedural mouth rinse, and we talked about the HVE last time. HVE is your high volume evacuation, or the suction, and we're going to talk about that a little bit more tonight too. And it has a trap that catches debris. So when you whatever gets sucked up in the mouth goes into this trap, and the traps have to be changed every couple weeks as well. Pre-procedural mouth rinses, or having a patient rinse with a mouthwash before treatment, can also lower the number of microorganisms that get into the air. The CDC says that there's not enough evidence to say we have to do this, but it can't hurt. So the CDC calls it an unresolved issue because they don't recommend that we do it, which means that we don't have to do it. Saliva ejectors. The one thing to know about that, and we met our saliva ejector last week, the little straw, that goes into the mouth to suck up only fluid. Saliva ejectors, don't let your patients close tightly around it. And typically to this, everyone goes, ew, I've always closed around it. If you are asked to close around it, close your teeth around it, not your lips. When you close your lips around this, there is a chance that there's suck back from the line into your mouth, which is a totally disgusting concept. So I never ask my patients to do that. I'll have them spit into it or have them close their teeth together. All right, and there's just some visuals on this, on the saliva ejector, the HVE, and the dental dam. Along with, there's a nice picture of the dental dam, along with the pre-procedural mouth rinse. So we talked a little bit about dental unit water lines last time, and the water lines are anything that deliver water into the patient's mouth. And, you know, if you leave flowers in a vase too long, you get that slime in the bottom of the vase. Well, you're going to get slime in the dental unit water lines as well. And so we treat these daily and weekly, just like we were taking care of a pool, basically. And so these lines have to be flushed out between patients. They need to be flushed completely at the start of the day. They should be flushed of all water at the end of the day. And each time we fill the water for their dental unit water lines, we should be treating it with a chemical that is safe for drinking, but not good for bacteria. And then typically we shock them weekly, as we would if you were using the pool analogy. You shock a pool every now and then. If you are shocking your lines, you can't use them, of course, so usually that's done overnight or over the weekend. Dental unit water lines will never deliver sterile water, so sterile water has to come from a separate source. So this just is a diagram of where the dental unit water lines are, so that you can get an idea. So anything that connects to a handpiece, anything that connects to an air water syringe, any self-contained water reservoir, and anything that fills water for a patient. So there you can see how small these lines are if you look into these little openings. And you can see what the slime looks like once it's built up. Isn't that nice? So offices and dental assistants take care of these. We do it, number one, by controlling the quality of water that goes in. So if you use spring water going in, you get a better product on the other side. Or if you use sterile water even. It won't be sterile on the other side, but it will be much better than it could be. The bacteria inside the lines, what they do is they build up on each other or aggregate, and then they break off and end up in the water lines. So typically this is not a problem unless the patient is immunocompromised, because all water lines do this. So your water at home that comes out of the faucet has microbes in it. Sorry to tell you. What our goal is to keep it below 500 CFUs, or colony forming units, which is what the EPA says is safe for drinking water. Here's just a list of what we do with our different laboratory and impression materials and how to clean them. Typically, what you want to think about is that anything that comes out of the patient's mouth needs to be disinfected immediately, and then it should be wrapped and labeled as disinfected, especially if it's going to be sent to a laboratory or out of the dental office. Pumice should be single dosed, so we use pumice for polishing, and so you should never be reaching into the same container between patients. So small container for each patient when you need it, instead of reaching in and contaminating a whole batch of it. Laboratory tools need to be disinfected as they were instruments, as if they are instruments. And then the impressions and dentures, you're going to rinse them disinfect them, wrap them, and label them. Okay, and so here's just some visuals on what these are. We remind ourselves what the lathe looks like. Here is a single unit dose of pumice. Here's a patient's denture and impression. And remember our case pans that we would place this in once it's been disinfected. Stone models are the hardest thing to disinfect. So what we want to do is disinfect the impression before it becomes a stone model. But you can spray a cast with iodophor or a chlorine product and rinse it and dry it if you need to disinfect a cast. Typically that only results if we put something on a cast that isn't disinfected. So save yourself time and disinfect the thing you're putting on the cast, and that works better. Okay, so the how, I think, is probably the more important. So whenever you are disinfecting an operatory, you are going to have your mask, glove, and glasses, and utility gloves on. With the utility gloves, which tend to feel like big moon gloves, you're going to remove each barrier without touching the surface underneath, or you're going to pre-clean the surface using a wet wipe or by spraying a towel and then wiping on the surface. Second step is to then throw away the barrier or throw the wipe away, get a new wipe, and wet the surface again. So after you have completed this process, you can take off all of your PPE and then place a new barrier with clean, ungloved hands. All right? So the utility gloves are used to prevent against microorganisms and contact with chemicals. So you have to realize that if these chemicals are killing microorganisms, they can't be that good for us, right? So most of them cause organ damage over a long period of time. So if you protect yourself now, you don't have to worry about this. Let's see. If the surface becomes contaminated when you're removing the barrier, you've got to disinfect it anyways. So only if you can get that off without touching the surface can you just place a new barrier on it. Let's see. We talked about where barriers go at the end of class last time, which is in the regular trash. And then we always want to spray the towel, not the surface, because that reduces the amount of spray that we have to breathe in. General patterns, we say, spray, wipe, spray, wait, and then dry or rinse the surface. If you're using a wet wipe, we say wipe, discard, wipe, wait, and then dry and rinse the surface. So what that wait is the time it takes the product you're using to kill tuberculosis. So use your appropriate PPE, use the right techniques, and then you and your patients are going to be protected. Questions about Chapter 7 at all? Anything muddy? Okay, silence tells me no. All right, let's go ahead to Chapter 8. And the process of processing instruments. That didn't come quite out like I expected it to, but instrument processing. Instrument processing is a 7-step process. And so throughout this, we are going to look at these 7 steps as if they are individual things that we do. But the reason that we call this a 7-step process is because we want you to start at the beginning and end at the end. You don't want to come in the middle, and you don't want to go backwards in the process. So when you are processing an instrument, you want to follow the cycle all the way through. The first step is at chairside. It begins at chairside. And it ends with quality assurance, making sure that we did everything correctly after we finished. It typically takes place in a central sterile or a sterilization area that has all the stuff we need, and we don't want to go back and forth. So we say that it is a single loop from dirty to clean to sterile to storage. Notice that clean and sterile are two different things, and we're going to see this as we go through. So here's my overview. Step 1 is transport. Step 2 is cleaning. Step 3 is packaging. Step 4 is sterilization. Step 5 is storage. Step 6 is delivery. And step 7 is quality assurance. And these pictures are just an overview to sort of jog you as you're going back through this. So, step 1, transport. You've got to do this with utility gloves on, and you need to take your instruments in a leak-proof container that has a cover on it. And I used to do a little demonstration of this. Walking along, all of a sudden you trip. You get a face full of instruments unless you have a cover on them. So the cover is there to protect you. This is a work practice control, something that we do to keep ourselves safe. At the chair side, you should be discarding all your sharps and all of your waste. Once you get into the contaminated part of the sterilization area, you are going to clean your dirty instruments. If you have time to go through with the process, there are 3 different ways that you can clean the instrument. If you don't have time, you're going to soak them in the sink. Basically, you're soaking them in what's called a holding solution, which is just dishwashing detergent that doesn't foam very much and keeps those instruments wet so that the stuff doesn't dry on them. So if I have time, I don't use the holding solution. But if I don't have time, I'm just going to set them aside. And you really think of this just like you would a piece of silverware. So if you have the time, ultrasonic cleaner, automated dishwasher, or hand scrub. Hand scrubbing is never a good idea because any sharp instrument can end up poking us when we're scrubbing them. So either we put them in a cleaner that is sort of like a jewelry cleaner, an ultrasonic cleaner, or we put them in a dishwasher that's been approved for dental offices. So I always think of my instruments like a fork with egg on it. If you leave that sitting in the sink, it's going to be impossible to get the egg off. And what is egg except protein, just like blood is? But if you soak it, whenever you have time to come back to it, it cleans much easier. And so the holding solution is for soaking instruments if I can't clean them right away. The least desirable way, as I said, is to clean them by hand or manually. But the ultrasonic is the best. And ultrasonics have special cleaners that go into them. The ultrasonic cleaner creates bubbles that burst. So we say that it creates cavitation, which is the bubble, and then implodes, which is the burst. And this pops the debris off of the instrument. So 5 to 15 minutes or so with an ultrasonic cleaner. And you can test your ultrasonic to see if it's working with foil. After you have cleaned your instruments and then rinsed them, you are going to use a rust inhibitor or other thing, especially if an instrument is hinged, to make sure that it does not, the steel doesn't rust on the instrument. When packaging, we're going to make sure that we package our instruments together for what they're going to be used for on the other side, so that a package of instruments contains just what I need, and I can use all those instruments together the next time I need them. So an example of this is the basic setup that we learned. And remember, your basic setup is the mirror, the explorer, the cotton plier. These should be bagged together because you know you're going to need all 3 of them at the same time on the other end. This is what makes life easy in the dental office, is how you package. So if I have a set of instruments that I use to do fillings with, I want that set of instruments to stay together through the whole process. Packaging has to be done using FDA-approved packages that have certain monitors on them. And we're going to talk about our monitors in a moment. So here's an example of packages. These bags are the most common that you can see through, so you can see the instrument. And these should always, your hinged instruments should always be open so that anything hiding in there can get to, the sterilization can get to it. Many offices use cassettes and they wrap them just like Christmas gifts. So that's another way of doing it. A cassette can also go into one of these clear bags as well. Flash sterilization is to wrap an instrument that is not, is to sterilize an instrument that is not wrapped up. So this is the way it should be done, packaged. But occasionally, we have an instrument that we need right away that there aren't any more clean ones of. And so the only time that this is acceptable is to sterilize the unwrapped instrument and then use it right away on the patient that we need it on. And this can never be done for an instrument that is needed for surgery, because surgical instruments have to stay sterile from all times until they are used on the patient. So we can't use this on surgical instruments. But flashing means to sterilize unwrapped. And it's much faster to do it that way. So our indicators, or the things that we use to make sure that we know whether something is happening or not, are on the packages. And so here are some examples of packages with the indicators on them. And the ones on the outside only respond to heat. So if a package gets hot, it's going to change color. This is my indicator. My integrator is inside of the package. And my integrator changes color if it gets time, temperature, and pressure all together. So we say these factors are integrated, meaning that they must happen together in order for the color to change. So clear here, colored here. So here's an enlargement of this. And this is the indicator before processing. So typically most of them are pink before they go in, or they might be light blue. And when they come out, they're going to be dark in color like this. So here's my inside one right here inside the package, and here's my outside one outside the package. Both on the same package, you see, but one of them is inside where the instrument goes. So the inside one responds to heat, pressure, and time. And the outside one only responds to heat. The significance of that is that it is possible for an instrument to get hot, but not to get pressure and time, which are what make sterilization actually occur. So the chemical monitors, and you can get further into this as you're reading, are visual only, meaning that they don't tell us something is sterile, they just tell us they've been through the process. So visually, as a dental assistant, when I'm looking at my instrument packages, if they're pink, they haven't been through the process yet. If they're cocoa colored, they've been through the process. And that process has other checks to be sure that they're sterile. But all I can say when I look at a package that has a cocoa colored label on it is say, yep, that one has been through my process. So here's an example of the wrapped instruments going through the process. So you can see here, there is color changing tape on the outside of these that has not changed color yet. The labels are there, but the tape is not colored. And then over here, you've got the stripes of the colored tape. So this is a very visual outside way to show that this has been through the process. So far, we have transported our instruments, we've cleaned them, and we've packaged them. 4 more to go. Sterilization is what comes next. And this is done using heat. If the instrument can't stand the heat, it'll melt. Then it goes into cold sterile, which we talked about in the last set of slides. But the 3 most common types of heat that we use in dentistry are steam sterilizers, chemical sterilizers, and dry heat sterilizers. So let's take a look at all three of these separately. So this is my autoclave, and it is a steam sterilizer. What it does is it heats up water under pressure to make steam, and the steam is pushed into the instrument packages, and it is the heat from the steam that kills all the microbes. This is a chemical vapor sterilizer. Instead of using water and steam, water and pressure, it uses chemical vapor and pressure to make a chemical steam or a vapor, and the vapor goes into the instrument packages and sterilizes the instrument. Alternatively, we have dry heat that does not use water or chemicals. It only uses high temperatures. And this is good, but high temperatures sometimes destroy our more sensitive instruments, so it's not as common. By far, the autoclave is the most common in the dental office. This is a type of autoclave that is faster and is mostly used for hand pieces. So this is used for sterilizing the drills. And then we talked about our cold sterile already. One of the cons of a cold sterile is that it cannot be verified by a biologic monitor, which means that I don't have any way to test that it's actually working. I have to trust that the science and the chemical are doing their job. I have no way to prove it. But with heat sterilization, I have ways to prove it. And we talked about these ways last week when we talked about spores. So we use a harmless spore in our autoclaves and in our chemical vapors and in our dry heats to make sure that if the spore is dead, then we know that all other things have died as well, because spores are the hardest microbe to kill. So the steam autoclave, its biggest problem is that it will rust things, and you can't put any closed containers in it. Typically, a cycle is about 30 minutes long, and it uses about 250 to 273 degrees to heat up the water under pressure. And we use the spore called Geobacillus stereothermophilus to test it. And if you look at this, it has the word steam right in it, STEA almost. So this is our steam tester. For chemical vapor, if you put the instruments in dry, they'll come out without rust. So that's a really good thing. But the chemical vapor is toxic, so there are trade-offs with this. You need really good ventilation to use chemical vapor. We also test this with Geobacillus stereothermophilus, and the cycle is typically the same, about 20 to 40 minutes at about 20 psi or 20 pounds of pressure. The dry heat sterilizers are what I think of as cookie baking temperature. So they're about 350, 375, and the biggest problem, of course, as I said, can't put hand pieces in them because they're too hot. And we spore test our dry heat. Sorry for that little thing there. Should go away. Good. With Bacillus atrophius. And Bacillus atrophius is just a different type of spore that is sensitive to higher heats. After sterilization, the instruments are placed in storage. Storage has to be away from water, away from chemicals, and you should always use the oldest package first. However, packages are considered sterile unless they are torn or something has spilled on them. So we call this event-related packaging. As long as no event happens to the package, it's good. Bringing it to the chair side should be delivered in a way that keeps them sterile. So if you're working on the same principle, bring the clean cover to the operatory. And to open them, you should open your instruments in front of the patient by peeling the pouch open. If you push the instruments through the pouch, then anything that's on the outside of the pouch could contaminate the instrument. So this is the aseptic way to open an instrument pack. And then the last step is quality assurance. How did we do? And quality assurance involves 3 types of monitoring. Physical monitoring, which means that when I use my machines, I'm looking at the gauges to be sure they're doing what they're supposed to do, kind of like when you're driving the car. You check your speed limit so you know that your car is going how you want it to go. So that's physical monitoring, is reading the gauges. Chemical monitoring are the outside and inside integrators and indicators on the package that change color. So I say chemical monitoring and color changing. They both start with a C, easy to remember. And then the last type that we haven't talked about is the biologic monitor. And the biologic monitor is the spore. So this is the only way to confirm that instruments are sterile, is by using a spore to test the autoclave or other sterilization method. And we do this weekly, and we have to keep the results. So this is what these spore test strips look like. So, we talk about spores, and you won't ever see a spore. And so we might have an image in our head of some little bug or something like that. But it's just a little envelope. These are called glassine envelopes. And inside are living spores. What we do is we place one of these test strips in the machine, and we keep one outside the machine. And then we send both the one that went through the machine and the one we kept out back to a laboratory, which tries to grow the spores. So they should be able to grow the spores from the one that didn't go through the machine, and they should not be able to grow spores from the one that did, right? Because the one that went in the machine should be dead. So this is how we test that the machine is working right. So what we're hoping for is a negative result, all right? So I used to laugh about this and say it's kind of like a pregnancy test. You hope for a negative result. And then I realized, some people do want to be pregnant. Never mind, I guess that's a bad analogy. I'm not one of them. So I'm kidding. I have one. That's enough. So typically there are 3 of these. And we send 2 of them through the machine, and we keep one out, and then we look. So you want a negative to pass this test. You do not want a positive. A positive means something grew, and that means that your machine is not working correctly. So here are some examples of the Sterothermophilus and the Bacillus atrophius. And if they put them both in the same package, they're called dual species. So most manufacturers make these packages with both of the type of spores, so that no matter what sterilizer you put them in, we can make a test through it. The most common cause of failure of sterilization is human error. So we make mistakes. One of those mistakes is if the instrument is not clean, it may come out with debris on it. And debris can't be sterile no matter what. So if you get an instrument on the other end of your whole process that has some schmutz, which is what I like to call debris, on the end of it, you've got to send it through the whole process again. You got to go back to step 1 and put it through the whole process. Remember, we don't join the process at step 4. We start at 1, end at 7 every time. If you overload the sterilizer or you improperly package your instruments, that can also cause a failure. And then the rest of the failures are usually machine related. And typically you call your dental service company and they come and give you a new machine until your other one gets fixed. Okay, so when processing instruments, the biggest thing, don't skip the steps. Go back to the start if you miss a step. All right. Questions on instrument sterilization? Everybody feeling okay about the steps? All righty. Okay. In just a few minutes, I know I'm going to have that fire drill, and I know you'll miss me terribly. But we're going to start Chapter 9. All right. So we are now getting into, and you'll be relieved to know that these presentations are a whole lot shorter. So there's a lot of chapters that we're covering. but they are very self-explanatory. So our objectives are basically to learn how to admit and seat a patient in the way that is accepted in the dental office. And typically this is pretty easy for us because most of us have been patients. So we understand what it is that people do. They come out to their waiting room, they say our name, they bring us back, they make small talk, they get data from us, and then they go and tell the doctor that we're ready, that we're waiting. And this is kind of the thing. But at the forefront of it, we want to remember that the focus is on the patient. Because when you become the worker, you are going to need, rest, breaks. You're going to have aches and pains. You're going to have shoulder and neck and back pain. Your dental team is going to be stressed as a team or fatigued as a team. But your patient always needs comfort, quality, and speed no matter what. So if you keep the patient at the forefront, you will not have to remind yourself to use the patient's last name, smile and establish eye contact, ask the patient to follow you, have the chair opened up so that the patient can easily sit, so the dental arms will open, either they'll raise up or they're open to the side. And then we've got basically two treatment positions. We either have our patients sitting upright for entry and dismissal for radiographs and impressions, or we have them supine, which is knees and shoulders even, basically, knees and head even. And that's treatment position. The only other position we put the chair in is subsupine or Trendelenburg, and this is for emergency. So a subsupine or Trendelenburg position puts the head lower than the feet so that the blood will rush to the head, and that is done for an unconscious patient. So make conversation, ask if patient has any questions, only answer the questions that you feel like you can answer. Don't answer any that you don't feel like you can. Just say to the patient that, let's ask the dentist when they come in. So what is teen dentistry? When you go looking for a job, you're going to see a lot of ads that say four-handed dentistry. That's what they want their assistants to be able to perform. Four-handed dentistry is what you're learning here. So four-handed dentistry is your two hands and the doc's two hands. That should not scare you. So when you see that, you want to say, yes, I've been trained in four-handed dentistry. Four-handed dentistry breaks up what we do into the zones of a clock. So if you're one of those people who has trouble telling time on a clock, you may have to refresh this a little bit. We're all so digital these days. You don't often look at clocks anymore. But so from 12 to 2 o'clock, nothing should be happening. All right. This is basically where equipment is located. From 2 to 4, this is where you're located. From 4 to 7 is where you transfer instruments and materials. From 7 to 12 is doc zone. Yeah, I know, doc gets the biggest zone, but they're the biggest pain. Just kidding. So six-handed dentistry is when you've got 2 assistants and 1 doctor. And this is typically for oral surgery, or if you're lucky enough to have a runner, meaning somebody who can go and get you equipment in case you've forgotten it. So what's in the dental treatment area? Our standard equipment. Here's the list, and we're going to do a little refresher on this at the end of the presentation. You want to remember that dental equipment is expensive, it's delicate, and the responsibility of maintaining it and sometimes even repairing it falls on us, on the dental assistant. So my advice is always read the manual. Get into knowing your equipment so that you know what to do with it and what not to do. This is an Alabama cart.
This is a fire drill. Please evacuate as if you're hearing the fire alarm. This is a fire drill.
Going out for my fire drill, guys. I'll be right back. Have a 5-minute break. I'm back. But I think everybody else left, which is okay. I'm going to do a quick attendance. Okay. Who's that in Turner? Hit your unmute if you can. See the little microphone with the line through it?
All right.
Hi.
It's Stephanie. The other two girls are still here. They're coming back.
Okay, so who's here?
It's going to be the two Stephanies and Joelle.
Okay, fab. Thank you, Liza. Appreciate it. I'm glad you made it. All right. Courtney! Where are you, Courtney? I don't see her. I don't know if she... I don't know. Okay. Sarah? Melanie, I see you. Hi, Kimberly. Hi, Jessica. Okay.
Hi, sorry. I dropped the remote everywhere and the batteries.
It's all right. How's it going, Mel?
I'm hanging in here.
That's good. Courtney! Okay, let's go ahead and get back. Oops. Sorry, I didn't mean to mute you. All right. So I'll come back to. Okay. So the Alabama cart is typically what's in the static zone from 12 to 2. The Alabama cart is like where you put everything you need. And we often stock it with all of the disposable things that we need. We put barriers in it so that we can easily reach and grab those during treatment. Sometimes there are actual dental units that are rear delivery, and they might live too from 12 to 2 in the static zone. And so your suction might be back there as well as the hand pieces for the doctor. So instrument transfer, let's chat about this for a little bit. Instrument transfers, your tray is set up from left to right in order of use, meaning that the first instrument you use is going to be the one that is closest to the dentist. So that should be at your left hand. We then transfer instruments with the left hand. The right hand is free to use suction and to ready for the next instrument. So if let's see, here's my patient. So if I'm the dental assistant, I'm sitting over on this side of the patient, and my left hand is what does the transferring, and my right hand is what does the suctioning. So we use a minimum of motion, and then if you're working with a left-handed dentist, all of this gets flipped. I've worked with both. left and right-handed dentists, assisted both of them. I started with a right-handed dentist, and then when I was about a year or two into it, they gave me a left-handed dentist, and that was definitely a trip. So it can be difficult to switch sides, but what you find is that it really doesn't make much of a difference. You get into the swing of it fairly quickly. So when you're transferring an instrument, you want to think about making sure that the working end of the instrument is towards the tooth. The dentist should not have to reposition the instrument. So if you see your dentist repositioning the instrument, you want to change the way you pass it so that they don't have to do the twist with their hands. It should be placed firmly into the dentist's hand, and the doc should not have to move their eyes from the operating field. So the dentist wants to keep their focus on the tooth so that when they reach out to grab an instrument, you're making sure that they can feel that the instrument is in their hand, which doesn't mean you smack it down, but you want to pass it with some authority, and you want to make sure that it's in position that the doc can just use it, go right into the mouth, and do what they need to do with it. So some specific examples: a Mirror and Explorer transfer is two-handed. So I will hold both Mirror and Explorer, and then I will transfer them this way. And I'm going to show you this after we get to when we get to our instruments, we'll work on that. And I'm still planning on making the rounds to everybody, so we can make sure that we get to touch some stuff before we get out there. Hinged instruments are transferred by being placed into the doctor's palm, and scissors or anything that has loops go right onto the doctor's fingers. Dental materials get transferred right near the patient's chin, and they usually are on a mixing pad or a slab. In anything that's in a syringe should be passed so that the patient can't see the tip of the syringe, but the dentist can grasp the syringe. Now, when we talk about syringes for dental materials, they are not sharp. So you can hide the working end of the syringe in your hand without worrying about hurting yourself. And then amalgam is placed into a carrier, and we'll talk about that a little more. So here is an etch syringe. And this etch syringe is going to be transferred so that the patient can't see this tip, because especially young patients will see this and they'll think they're getting a shot and they freak out, and then we've lost them. And like the whole appointment just goes to heck. So we hide this in our hand when we transfer it. Amalgam, which is the silver filling that we use, is placed into these little ends right here. And the small end goes first. And then my question to you is, could you place this in a cavity yourself? And if you don't know, how do you find out? And the answer is yes, you can. And you find out by going to the State Dental Practice Act and making sure that you understand the levels of what you can do. Let's see. So the way that the operator touches an instrument or grabs the instrument is called grasp. And so for us as dental assistants, we don't often grasp the instrument. What we do is transfer it. So we're not worried about how we hold it. We're just worried about keeping our fingers as far away from the working end of the instrument as possible. And so if you're going to use the instrument, though, you can either use it in a pen grasp, which is the top one. An Explorer is used in a pen grasp. A palm grasp, which is the middle one. And then a palm thumb, which is used by the dentist when they're using a periosteal elevator, which is a surgical instrument. Okay, so now if everybody would just, if you have a piece of paper, number it 1 to 11. If you don't have a piece of paper, that's okay. Follow along anyways. But grab a piece of paper, number it 1 to 11, and get ready to quiz yourself. It's not a quiz you'll turn in, but it is just a way of sort of looking at how much work do you have to do about knowing the equipment in the dental operatory. So let's go. All right, so here's 1, 2, 3, and 4. And I'd like you to see if you can name each little thing. And this is in your chapter in the textbook. I'll give you a minute for that. I can't remember if I put the names on here. I don't think I did. I didn't. Okay. So I will come back through. So if you're unsure, we're going back through. Here's 5 and 6. And I just wanted you to take special note of that on number 6. Here we have 7 and 8. Another special note. And here's 9 and 10. And there's two labeled number 9 because they're the same thing, just different styles. And 10. Okay. I'm going to go back here and we'll go through these quickly. And so don't be discouraged if you didn't know them. If you did know them, give yourself a big yay. But this is just for your own good so that you go back through because it's going to be overwhelming when you think about the instruments. So to get the equipment down is important. So we have the saliva ejector. This is where the saliva ejector is going to go. We have the HVE. This is where the HVE goes. And we have the air water syringe here. So this is the air water syringe, and this is the air water syringe tip. This is the dental curing light. If you've ever had your nails done, you know what this is, right? Okay. Number 5 is the amalgamator or the triturator, depending on how you remembered it. This is what mixes the amalgam capsules and also some of our dental cements. This is a rheostat here, and the rheostat is what controls the speed of the handpiece, kind of like a gas pedal. And then this little dot right here on the rheostat means water. So right now, this rheostat is in the off position for water. So when the dentist steps on the rheostat, they will not get water coming out of their handpiece. But if the button was flipped towards the blue circle, they would get the water. We have the dental unit here in number 7. And number 8 is the dental light or treatment light. Okay, down here is the control pad. What this usually does is raise and lower the chair. And so how would you protect this surface best during treatment? Because you know doc's going to be touching it with their glove. You're going to put a barrier over this surface right here. And we've got the intensity switch. This changes the intensity of the light from high intensity to low intensity. And then here we have the on-off switch. So this is how I turn the light on and how I turn it off. Number 9 is the assistant stool. And number 10 is the operator stool. And just to, so you can tell the difference between this one and this one, is the ring for the feet. So only assisting chairs have the footrest on them. Operator chairs do not. Okay. Oh, I forgot number 11. Number 11. What position is this dental chair in? Your choices are either upright, supine, or subsupine. The answer is supine. And this is a foot control for the chair. So we usually have on the dental unit there'll be controls for the chair, and also it can be controlled with the foot, which definitely saves infection control. All right. Any questions? Okay. We are going to move on to chapter 10. And hopefully that just gave you kind of an overview of the equipment. Good. All right. And we're going to talk about moisture control. Moisture control is one of the most important things that we do. So it is better to be late on an instrument transfer than it is to let the tooth get wet if you are trying to keep it dry. And a lot of times when you're assisting, you're going to feel like you're an octopus. There's stuff coming all over the place. How are you supposed to keep this field dry? Patients' mouths are like swimming pools. It's very frustrating. No, but what you are going to do, I'm just going to scoot through the objectives. So I say, welcome to the deep, dark swimming pool called the oral cavity. Basically, it's dark in there, it's wet in there, and Doc needs for it to be light and bright, and that is what our job is. So we do this by isolating using either a cotton roll, a dry angle, or a dental dam. And we do this by evacuating, which means suction. And we do it by mouth rinsing, which means to clear the field. So we're going to start with a limited mouth rinse. Limited mouth rinses do not interrupt the procedure. Limited mouth rinses only wash the tooth that we are working on. And they are a very fast activity. You need an air water syringe and an HVE to perform a limited mouth rinse. And you will take your HVE and you will place it over the tooth, and then you will take your air water syringe and you will hit both air and water together and then air by itself. So these little buttons here, one is air and one is water. So you're going to put your thumb and hit them both together, and then you're going to hit just the air. So basically what you're doing is you're spraying the tooth and then drying it off. And this should be completed in 10 seconds or less, really quickly. And so this helps the doc to be able to see what they're doing, and doc is either going to check or then resume the procedure. A lot of times we do this while doc is changing a burr on the handpiece. So while they're busy, I'll do a quick rinse, and then when they come back to the tooth, it's nice and clean and they can keep going. A complete rinse is done usually after either impressions or anesthesia, or at the end of a procedure. And basically, it's like what it sounds. They get to swish. Now, some chairs will have the cuspidor so that the patient can take a drink and swish themselves. But what happens when a patient is numb and they try to do that? Right? They drool all over themselves. So doing a complete rinse for your patient is a really nice thing to do. And what you do a complete rinse with is a saliva ejector or an HVE and the air water syringe. So you are going to do these things. You're going to have the patient turn towards you, and you're going to spray their whole mouth with air and water, and that's going to bring everything towards you because their mouth is already turned towards you. Saliva ejectors are only for liquids, and we've talked about them, I think, well enough. And HVEs are for debris and saliva and blood and water. So HVEs do all of everything. Most dentists, when they say suction, this is what they want. They don't want the small one. They want the large one. So it is also useful as a retractor. So it's good to pull the cheek so that we can get more light and more visibility. And it will also keep the tongue where it's supposed to be. You can hold your HVE either in a thumb to nose, which means that the HVE is between your fingers and your thumb is on the top end of it, or you can hold it as a pen. So 2 ways. And you won't really know until you grab one which way you like best. I find that I like the thumb to nose for the control that it gives me. But if it's a long procedure, I may want pen grasp. You are always going to place your suction before the dentist positions their mirror and handpiece. So you go in first, and you're going to place it on the side of the tooth that is closest to you. And you want to make sure not to block the doc's view. Not too much to do. So there's the grips. And there's the placements for each areas of the mouth. Cotton rolls are one of the most popular ways that we isolate or keep our teeth separate. Cotton rolls go into the vestibule, which means that they go between the lips and cheeks and the teeth. We want to place these sometimes over Stenson's duct, which is the duct that the parotid gland drains into the mouth up here, the Sour Patch Kid one. So we'll place a cotton roll there to absorb moisture. Dry angles can also be placed to absorb moisture there. Dry angles are triangle-shaped pads that absorb moisture. And I know I have better views of that coming up. And then we can also use the rubber dam. Now, we have talked about rubber dam. Rubber dam must be used for root canal, which is what you see here. And typically that is a single tooth that's isolated. When a doc chooses to do rubber dam for fillings, you're going to isolate more than one tooth. And this is typically a procedure that requires a lot of practice. Placing a rubber dam is not an easy procedure. So you will probably not place the rubber dam. You may have to punch it, but you won't probably place it, at least not for a while. There's a great video that's attached with your Evolve on this procedure. And if you're having trouble finding it, just go to the chapter and look for the procedure videos there. And that'll show you a little bit more about how to place and remove. Here's just an example of a couple of these in place. And I just wanted to go through the different items, some of the different items from this chapter. So this is a rubber dam punch. And what it does is it punches the holes in the latex that are going to be for the teeth. So it has different sized holes here because our teeth are different sizes. The hole for the clamp is always going to be the biggest hole. And then the other teeth will be chosen accordingly. This is the clamp. The clamp is what goes over the tooth to hold that piece of latex down. And there are different types, different numbers. The numbers, thankfully, are on the top of the clamp. So if you're asked for a clamp, you just are looking here for a number. Anything that has just a number is a clamp that has wings. So these are the wings. Anything that has a W in front of it is wingless. It has no wings. See, no wings. An 8 is for maxillary molars, and a 7 is for mandibular molars. And you'll do well to remember that. You probably won't remember it. But these are, like, getting the numbers down on the clamps is hard. And so usually what I do is I will ask the doctor what number they'd like, and then I can at least read the clamp and find it. So this is probably one of the best tips that I can give you. When you're speaking with doctors, sort of take the knowledge that you have and turn it into a question. So you know that clamps have different numbers on them. You don't know which numbers they're used for because you forget. Everyone's going to do that. So how do I take that knowledge and talk to a doctor? I'd say, Doc, what number would you like? And then it puts it on them instead of on me. This is the clamp forceps, which allows me to pick the clamp up and place it on the tooth. And here we have the rubber dam itself, the template, which helps me to punch the holes, and the napkin, which keeps the patient's face dry. And this is the final holder of the rubber dam. This is the dental dam frame. Frames that are made of metal show up on x-ray. And the way we say that is radiopaque. So we typically don't want to use the frames that are made of metal when we're doing root canals because we need to take a lot of x-rays then. So there's the setup for the dental dam. Okay, mini quiz. What's this? Saliva ejector. Okay, here we have something that we are placing in the cheek. It's a pad, it's triangle shaped. This is the dry angle, and we're placing it over Stenson's duct. And what's this here? This is the HVE. What's the difference between A and B? Well, one of them is disposable, and one of them is reusable. I'm sure you can tell me which ones. So, to remember that a dry field is more important than being ready with the instrument. So keep the suction in there, and if you have to twist and turn and make them wait a few minutes, that's okay. It's more important to stay dry. Any questions about moisture control? Okay. All right. So we're going to talk a little bit about the dental exam. And the biggest part of this, and the part that I really want to get to this evening, is tooth surfaces and tooth numbering. So we're going to come through here a little bit. We remember that the record is a legal document, that we take registration, medical history, dental history, and give our patients HIPAA informed in the record at each visit. We don't have to give the HIPAA at each visit, at least once for our patients. But the registration, the medical and dental history, those are all going to be confirmed at each visit. The clinical exam involves the dentist taking a look at everything, and we do this with visual inspection, with palpation, which is using the fingers, with instrumentation, the Mirror and Explorer. We take x-rays, we take pictures of the inside of the mouth, and we use photography. So all of those things are used to give us a picture of the patient, our clinical exam. Vital signs keep a measure of the patient's overall health, and you will probably not do this very often. And if you do, hopefully, you are doing it with a machine. So it is not, it's not really possible for me to teach you to take blood pressure in this kind of setting. But you can read and watch the videos on how to do this. If you can get a hold of a blood pressure cuff and practice, that's great. But most offices are going to have the machines to do it for you. And partly because the machines are really accurate as long as the batteries are fresh. And they're so much easier. We just don't have the time. Now, how many of you, and I have to do this just to see, but how many have had your blood pressure taken in a dental office? Has anybody had it taken in a dental office? Yeah, right. But maybe before, do you have, like, before having a tooth out? So, very rarely, right, do they do this. Does anybody's office do it all the time, or nobody knows? Not really. We should be doing this, but most offices don't. And I can remember I had a patient once. I sat him down and I went to take his blood pressure, and he was like, "I'm not at the doctor. I don't want you to take my blood pressure." He got really mad at me. for attempting to take his blood pressure, because patients expect it in the medical offices, but they don't think about it. But the reason we take it is because we are injecting anesthesia, and typically we are doing things that we want to be sure that our patient is healthy. Some things to know. The appropriate pulse for an adult is 60 to 100 beats. And you take that on the radial artery. So all arteries have a pulse. All arteries will thump. But the only ones we can feel are the ones on the outside of the body. The radial artery is on the thumb side of the hand, of the wrist. So find your own pulse. If you've ever done an exercise class, you probably know right where this is. Yep. And if you can feel it, you're alive. Yay. I know, I'm boring you to death, but at least you're still alive. The blood pressure should be 120/80. And this is a measure of the heart as it is pumping and the heart at rest as it is filling. So systolic, the higher number, and the first number that we list and the first sound that we hear, is the left ventricle pumping blood into the body, oxygenated blood. The diastolic is the heart at rest, when it's filling with deoxygenated blood. And we typically take this with a sphygmomanometer and a stethoscope, or the automated device. Okay. So we're now going to talk about charting. And this is probably the biggest thing you'll be involved in on a patient exam at the start. So a clinical exam, when we are recording our patients in dentistry, is done with symbols. And the symbols are basically a shorthand for what we see in the patient's mouth. And we use abbreviations in color to sort of direct us on a record. And when something is in red, it means that we are planning to do it in the future. It needs to be done. When something is in blue, it means it's already been completed. Someone has already done it. It may be me, the dentist of record, or it could be a dentist you had 10 years ago. But somebody has already done this if it's in blue. All right, so here is where we are going to review our two surfaces and our numbers. And let's see if I can do this. Okay, so to review our numbers, so hard to do. We are going to start on the top right, and because this patient is missing number 1, we're starting at number 2. And so check your top right. See how many molars you have back there, and you can count. So this is 2, this is 3, 4, and 5. There we go. That's a little bit better. Okay, so this is number 2, number 3, number 4, number 5, and then that task that I gave you a few weeks ago, 6, 11, 22, and 27. So what tooth is right underneath tooth number 2? That would be tooth number 31. On the other side of the mouth, what tooth is right under number 15? That would be number 18. All right, so just kind of a review of that counting. And now I'd like to get into the surfaces. Okay, so we use abbreviations to talk about the surfaces in the mouth. And if you've taken chapter 4, I think everybody, I think everybody's taken chapter 4. Almost everybody. We have a name for the outside surface, or the surface that we can see. All right, so if the surface is touching the lip, we call it labial or facial. So that is typically the anterior teeth, from tooth number 6 to tooth number 11, And then if we were to look at the lower, would be tooth number 22 to tooth number 27. All right, so if it touches the lip, this is the facial surface. People don't use labial that much, they use facial. All right, so my facial surfaces are out here. If it is a back tooth, this side touches the cheek. So this surface is called buccal. The surfaces of the teeth that are on the inside are the lingual surfaces because they touch the tongue. And then this is where it gets fun. For back teeth, the part that we bite on is the occlusal surface. This is the chewing surface. Only posterior teeth have an occlusal surface. Anterior teeth have an incisal surface. That is the very edge of the teeth that we use to cut into things or bite into things. The mesial and the distal are typically the hardest surfaces that people have issues with. So let me I'm going to take a tooth out here. And I'm going to take another tooth out here. Yeah, I'll do this one. Okay. Good. All right, so I just took 2 teeth out of my model. And taking the 2 teeth out of the model allows me to see all the surfaces of one tooth. So every tooth has a mesial surface. And so I look at this one tooth and I say, which side of this tooth is closest to the midline? Well, the midline is here. So the side of the tooth that's closest to the midline is this side, right in here. The side of this tooth that's furthest away from the midline is this tooth, is this side of it, right here. So the mesial side is that side, and the distal side is that side. So if I put this tooth back in place, all of a sudden you can't see the mesial and the distal sides anymore because they are touching the tooth next to it. You see that? So when you place floss in between, you are hitting the mesial of one tooth and the distal of the other on these. So our abbreviations go mesial distal, MD, and then so on and so forth. And we combine them to form a description of where we are on the tooth, because the doc is going to use this to talk about, close up. Here I am. Because the doc is going to use this to talk about where decay is on the tooth, where the cavities are, or where the existing fillings are. And then those existing fillings or decay are going to be charted by us. So basically, doc speaks in this language using abbreviations, and we're expected to be able to transcribe it and put it together. All right, so when they say MOD, what they mean is mesial, occlusal, distal. When they say BOL, they mean buccal, occlusal, lingual. When they say MILF, we say LOL. Just kidding. That's my bad joke for the night. Do you like it? Okay, thanks. Yeah. What you say is MILF instead of MILF. Okay. And when they say OL, they mean occlusal lingual. So they keep using the abbreviations to talk about this. So let's take a look at this on teeth. Teeth that we can see a little bit closer up. So any surface that is in between is called interproximal. And the interproximal surfaces are either mesial or distal. They can't be both. So the side of the tooth that is closest to the midline is the mesial side, And the side of the tooth that is furthest away is the distal side. So what you end up with is you end up with the mesial of one tooth touching the distal of another tooth until you get to the very back. And then this side is the distal because it's the furthest away, but it's not touching anything. We can do the same with this picture here of the front teeth. So this patient has cavities in between their two front teeth, all right? And these are actually MILFs right here. So this is a mesial incisal lingual facial cavity. And so I will call it an MILF. And I call it that because the lingual side of the tooth is dark. The facial side of the tooth is dark, the side that touches the lip. The mesial side is involved. And here's my midline, so this has to be mesial, closest to the midline. And the edge of it is involved, the incisal. So this is the MILF, and on both of these. So at the midline of the mouth, the very center, is the only place where a mesial touches a mesial. Let that blow your mind for a second. So practice that. Take a look at it. See if you can make that make sense to you. Because it's difficult to get the surfaces. And if you're having trouble, I would be happy to do a review video. So anybody who wants that, just give a yell by email and I will do it again on a review. Here we have interproximal decay on a posterior tooth. And if we say that the midline is this way, then this must be the distal side of that tooth, and this must be the mesial side of that tooth. Here, this is the mesial side. So we would call these MOs, DOs, and MOs because we've got the mesial side and the biting surface, the occlusal side. So back in the 1800s, a very famous dentist called G.V. Black was the first to notice that decay happens pretty regularly in the same spots in our mouth. And so he gave them classes. And he named them after Roman numerals. So if you are rusty on your Roman numerals, we're going to brush up. So this is a class 1. This is a class 2. Class 3. And then IV is class 4. V is 5. And VI is 6. All right, so that's a Roman numeral refresher there. But we're going to take a look at each one of these type of decay. This is what G.V. Black said. All right, so cavity class 1s are in the pits and the fissures of teeth. So here, this is the pits and fissures. These are on the biting surface. So these are class 1 cavities. They're pit and fissure cavities. Class 2 cavities are in between the teeth on back teeth only. So class 1s can be anywhere there's a groove, but class 2 have to be in between on back teeth. So here we have some cavities in between the tooth on the back tooth. Notice this one here is not in between, it's only on the biting surface. And so this is a class 1 cavity. So here we have class 1 and class 2 on the same tooth. Here's a class 1. Here is a class 2, and a class 2. You can see in these pictures how nicely the rubber dam really isolates a tooth. And these are all labeled. So this is a class 1 occlusal, class 2 MOD, class 1 occlusal in the distal pit, class 2 MO. We have DO, DO, and MO. And then we have buccal and occlusal, class 1s. So you can go back through these to sort of quiz yourself, because if you're doing this in present mode, it will not give you the answers till you click. And then we've got class 3, 4, and 5. So class 3 cavities are cavities that are in between the teeth but on front teeth. So class 2 are in between but on back teeth. Class 3 are in between on front teeth. Class 4 cavities involve the biting edge of the tooth as well. Sorry. And then class 5 are gum line cavities. So let's go through these. We've got a class 5 on the facial. That's a gum line cavity on the facial surface. We've got a MILF here, a class 4. And why is it a 4? Because it has an I in it. We've got a class 3 that is in between the teeth but doesn't involve the eye, doesn't involve the edge. And then we have class 3 and 5 combined there. We have a class 4 MILF down there. And then a class 3. So charting symbols are how we draw these things. The good news is, my friends, you're all going to be using computers. Very rarely are people actually drawing in colors anymore, but we have to be able to translate them. So anything solid means silver filling. Anything outlined means tooth-colored filling. Anything that is cross-hatched, has little lines, is metal. And metal will typically only be on the lingual surface. And I always say, unless you're Lil Wayne, because he had the grill, but nobody has a grill anymore. Even Lil Wayne got his grill replaced. So it's very rare that you're going to see cross-hatching on the facial. It's all going to be on the lingual, because most of us don't want metal showing when we smile. And so this is what it looks like. Now, your textbook has, in the Interactive Dental Office, 1 million chances to practice charting. And I would just, take advantage of them. Practice the charting. Because the charting practice is really worth it to sort of get the idea of what you're going to be doing in the dental office. Because what Doc says is, number 1 needs to be extracted. And what you need the chart to say is this. Just the line through number 1. So this diagram tells you what each thing is, but it won't in real life. In real life, it's just going to be the picture. So a class 1 cavity on the occlusal looks like that. A patient who has a sealant looks like that. A gold crown looks like this. So you can go through each one of these to sort of give yourself an idea of this. And I'm pretty sure your book has all of the symbols outlined for you. If not, I also have something I'm going to post that will be helpful. Okay, so this is just an example of charting in the computer environment. Different charts look different depending on the computer program, and you will get used to them. But what they all have in common is the fact that they use red and blue to denote things that either need to be done or have already been done. Greens are usually watches most of the time. So here's an example of charting on paper, which very few people do anymore, but you can click for a key to read it. And we go through that. Okay. The last part of this has to do with treatment plans. When a patient comes into the dental office, we have 3 levels of care. Either we offer them emergency care, which is like the rental car, just get me to my destination, I'll give it back, I promise, right? The rental car is for relief of pain, basically. It's problem focused, which means I'm not looking at the whole mouth, I'm just looking at what is bothering the patient. Standard care is the economy, the midsize. It's brings the teeth back to function, but doesn't have too much fancy about it. And then optimum care is the luxury model. It's everything the patient could dream of having done. So if you've ever dreamed of changing the appearance of your teeth, you want optimum care. You want the luxury model to give the best aesthetic and functional smile that you can have. And those are the levels of treatment in the office. We typically will have to record the treatment sequence and the entries. And so I have a couple examples of how this looks in a dental chart. And remember, charts are computerized, so you'll be typing it. If you're lucky, you will get to observe a lot of these before being asked to do it yourself, or you'll just be given dictation, which means you'll have to type while the doc says what he wants you to say. And we do this in the progress notes section. We're including what tooth we worked on, what type of moisture control we used, what dental materials we used on the tooth, and the anesthetic that we used, and any instructions that we give the patient when they're finished. So that's what that looks like. Okay. The last thing is just about the fees. Typically in most offices, we're going to give this right over to the front desk. So if you're thinking about cross-training, you want to realize that scheduling the patient is part of this, their next appointment, any payment they need to provide, and then insurance claims as well. All right, so questions on this at all? Lots of information tonight, for sure. And usually I do 2 more chapters, but you're all so lucky you don't have to have that. So next time what we're going to do is we will explore medical emergencies and pain control. So we'll be looking at anesthetics and then how we deal with any medical emergencies that may happen while the patient's in the dental office. So other than that, you are all free to have a wonderful night. Look at me 5 minutes early. So go ahead and break in with any questions you have. No questions.
Sorry.
Okay.
We are doing, for exams this week, we're doing 7, 8, 9, 10, 11?
Yes, if you can. Yep, that's what you
Okay.
want to shoot for. Yep. So remember when I threatened you with it's going to get worse? Well, here it is getting worse. Yep. Yeah. So do your best to get there. You will have coming up a couple times where you only have a chapter or 2, so you may have some catch up time, but push on, my friend. All right.
Okay.
Thanks. Have a good
Thank
night.
you.
Too. No
Yes.
problem.